The maintenance therapy after transplant is again guided by evidence, and we had two New England papers, one from the US, one from France, where everybody who had transplant was then randomized post-transplant to either lenalidomide or placebo. And those studies were both quite consistent that the PFS without maintenance therapy was approximately 2 years, and with the addition of maintenance therapy with lenalidomide, that increased to about 4 years. And so that's pretty clear data, and it's consistent from both studies. The OS, of course, is interesting and important, and the OS in the American study showed an improvement, but the French version did not. Interestingly, you would have probably expected the opposite because it was the American study that allowed crossover, so that if patients were randomized to placebo, they could cross over to len maintenance at the time of progression, which would clearly decrease your ability to detect an OS difference. But the fact that that didn't happen suggests that the fact that the American study didn't show that really does suggest that that PFS benefit does eventually translate into OS benefit, which is what we usually think about in oncology. The whole reason we use these surrogate endpoints, response rate typically correlates with PFS, PFS typically correlates with OS. So that's why the FDA has allowed PFS to be used as a surrogate endpoint in not just in myeloma, but in other tumors. But that would support that premise. Now, the pushback some people have for maintenance therapy is that, are you bringing out resistant clones? By using lenalidomide maintenance, might you be selecting myeloma clones that are difficult to treat? My response to that would be, if that were truly the case, then how are we seeing an OS benefit in the len maintenance in the US study? And secondly, we need to also be mindful that when you're looking at OS, this is not the primary endpoint of the study because the study only defines that initial therapy. The minute the patients progress, you lose all the randomization and controlling for confounding variables. And that's where access to drug becomes a big difference across the Atlantic. In the US, when patients were progressing on len maintenance, a lot of them could be salvaged appropriately with bortezomib maintenance, et cetera. In France, some of those patients who progressed on len maintenance went on to get more IMiD maintenance, which in 2015 was either more len or more thal. And so, in 2005 to 12 when these were done. So I think it's important to remember that OS depends not only on the initial randomization, but on subsequent salvages. And so you may lose that benefit of the initial randomization. And then the last important point to make about len maintenance is toxicity. Generally, it's well tolerated. There are studies to show that patient-reported outcomes, quality of life measures don't seem to drop significantly. However, we do know that there is a slight increase in secondary malignancies. Both studies show that, the French and the US. The rates can be anywhere from 1 to 3% in the control arm up to 6 to 8% in the interventional arm. And so what do we do with that data? Again, the PFS and OS data from the len maintenance speaks for itself. However, we also do recognize that patients need to be keeping up with age-appropriate cancer screening like mammograms, colonoscopies, because the malignancies that patients got were all over the board. They could be hematologic, solid tumor, but in the end, many of us feel that the len maintenance benefit does seem to override the minor risks of the len maintenance. However, at the end of the day, it's always a patient-specific decision. So len maintenance probably has the most data, and there was now a recent meta-analysis showing that across several studies, the OS benefit was maintained, and now len maintenance is on label per the FDA because of this OS benefit. Are there other alternatives to len maintenance? There are some smaller studies with bortezomib maintenance. Some of them are complicated study design because it wasn't just a maintenance randomization, may have also deferred in the induction part of the therapy. But certainly bortezomib maintenance is another option. One of the limitations is because it's a parenteral drug, it can be challenging to administer on a long-term basis. There are newer studies coming out with looking at ixazomib, which is the oral proteasome inhibitor, given the convenience of that drug, to look at that in maintenance settings. And also daratumumab, the monoclonal antibody, will be studied as well in maintenance setting. And finally, even now, we feel that len maintenance, while important, may not be enough for high-risk patients because those patients still seem to do worse compared to their standard risk counterparts. And the Emory group presented a retrospective study that showed that combined maintenance with len bortezomib dex can actually result in much better PFS outcomes. Admittedly, we don't have a randomized prospective study to support that, but if somebody is really high risk, consideration should be given to doing more than len maintenance in combination therapy. So going back to our 61-year-old female, she had the triplet therapy, stem cell transplant consolidation. She did have translocation 14-16, which is considered to be a high-risk feature, and therefore len maintenance would be appropriate. One might also consider if somebody had translocation 4-14, given the data that PIs or proteasome inhibitors may be better able to overcome that high-risk finding, perhaps PI-based maintenance may also be appropriate. But for this patient, len maintenance would reasonably, scratch that, but for this patient, len maintenance would be a very reasonable approach.